Welcome and good afternoon, everyone. My name is Claire Sheehan, and I'm the President and CEO here at the Alliance for Health Policy. We are a nonpartisan, nonprofit organization dedicated to helping policymakers and the public better understand health policy, the root of the nation's healthcare issues, and trade-offs posed by various proposals for change. Today, we are thrilled to present the webinar, Demystifying AI Tools in Healthcare, an Introduction for Federal Policymakers, and I will be the moderator for the event. For those of you who don't know the Alliance, we've served as a trusted educational resource for the health policy community for more than 30 years. And today's webinar will explore the current legislative and regulatory landscape of AI in health, current risks and pitfalls of AI tools, and the role of governance and equity in AI. I think, as a 30-year-old organization, I can say that when this organization was founded, no one probably envisioned the content that we're taking on today, but we're really excited to be talking about not just health policy today, but the health policy of the future as well. This event is part of our year-long program on AI called the Signature Series. We bring together health policy stakeholders from across the continuum, collecting insights, conducting strategy workshops, and leveraging those insights into our educational programming, including our April Summit, this webinar, and an upcoming congressional briefing on October 2nd. Please look at our website to review the summit content, read our workshop report, and learn more about all the work we've been doing in AI this year. In addition, we are always updating our LinkedIn feed with the latest and greatest in programming, so if you're not following us there yet, please do click over and follow. We know from the listening tours that we have conducted with legislative audiences and other policymakers that AI can be an intimidating topic, and it's hard sometimes to know where to start. Our hope with this webinar is that we've created an opportunity to delve into the topic, whether it be from the beginning, perhaps with some knowledge, or from a perspective of someone who knows quite a bit about AI and wants to learn what's happening today. This webinar will also be recorded and available online, so you can return to it or share with others once you are through. We're excited to showcase an overview of the current landscape, along with some key questions to consider during this webinar that will hopefully help you in your work and inform the work that policymakers across the country are doing. With that, I wanted to just take a moment to thank our sponsors, MITRE and Siftwell. We are so grateful for their support of this event. None of our programming happens without the considered support of our sponsors, and we are so happy that we're able to do this work today with that support. We'd also like to thank our speakers from Epstein, Becker, and Green for the pro bono support of this event, and all of our speakers who are sharing their expertise. We are very eager to get to the content, but did just want to share that today's presentations and panel has a Q&A session at the end, so you have a role today too. We're eager to hear your questions. You can share them anytime by, you should see the dashboard on the right side of your web browser that has the speech bubble icon and question mark. You can see a very helpful illustration here. And use that speech bubble icon to submit questions you have for the panelists. You can do this at any time in the programming. You don't have to wait for a special period for questions. We're going to collect these and we'll address them during our Q&A portion of the webinar. Throughout the webinar, you can also chat with our team about any technical issues you may be experiencing. We can assist you. If we don't get to your question in the Q&A, please don't hesitate to reach out to events@allhealthpolicy.org, and we can do our best to connect you to additional information. And again, look for us on our LinkedIn feed. Our website is a great resource as well, and you can follow us on Facebook and YouTube. So with that, let's get started. I wanted to introduce today's esteemed panelists. We're so excited to be working with all of them. They bring unique perspectives, and there's so much content in this webinar that I think is going to be helpful for everyone listening. So we want to start with Lynn Shapiro-Snyder. Lynn has been a leading healthcare attorney at EBG for over 45 years, addressing a wide variety of federal and state healthcare issues. She's advised companies on risk mitigation related to the creation and use of AI tools in both clinical and administrative applications. She's also the founder and chair of the Women Business Leaders of the U.S. Healthcare Industry Foundation, a network of over 1,400 senior executive women who lead healthcare companies. Next, we have Rachel Snyder-Good. Rachel joined Epstein Becker Green in March after 11 years on Capitol Hill. And since joining Epstein Becker Green, Rachel has helped healthcare clients draft AI compliance programs and is currently advising on a wide range of healthcare companies regarding the creation and use of AI tools in healthcare. She is also closely monitoring the regulatory and legislative AI action. She's going to share some of that with us today. Dr. Maya Hightower is also joining us. She is the CEO and founder of Equality AI, a company whose open source responsible MLOps toolkit allows developers to identify and mitigate bias in data and AI methods. She's the former EVP and Chief Digital Transformation Officer at the University of Chicago Medicine and is a leading voice at the intersection of healthcare, AI, digital transformation, and health equity. Dr. Hightower is a champion for responsible AI, ensuring that the digital future of healthcare is equitable and just. Our final panelist is Dr. Nicoletta Economou. Nicoletta serves as the director of Duke Health and Evaluation and Governance Program, and she also is the founding director of the Algorithm-Based Clinical Decision Support Oversight, leading the operations and framework design for the governance, evaluation, and monitoring of ABCDS software at Duke. She also leads initiatives relevant to evaluation and governance of health AI technologies, along with leading operations for the Coalition for Health AI as a scientific director, known as CHAI. You can read more about the bios of our incredible panelists at the Alliance website, and I encourage you to dig in and also see some of the other publications that they've done in the past. So with that, I want to turn it over to Rachel and Lynn.
There we go. Hello, everybody. Lynn Shapiro-Snyder, and we're going to get started. Let's go to the next page. This is the typical disclaimer. Rachel and I are both attorneys, but we're not here to provide legal advice. It's for educational purposes only, and it is a pretty thick deck. We're going to skip some pages for you to read later. It's like a paperback book a little bit, and then some pages we're going to spend some time on. And we do include an index with some more details about actual regulations and provisions that have come out recently from our HHS organization. So just wanted to give you the heads up. If you see us turning pages quickly, it's because we want to cover as much information as possible. And let's get going. Next page. So just to explain who we are, Epstein Becker Green was started in 1973 just to set up HMOs in America. We only do healthcare, life sciences, and employment law. We have consulting and advocacy, and it's a unique platform. It's a very super boutique law firm that really specializes in this area. Next page. And there we are, and we've already been introduced. So let's go, Rachel, take us through the agenda.
Okay, so what do we need to know to get started will be our first topic of conversation. Then we will go to what is AI and how is AI defined? What are the current potential pitfalls and risks of AI tool usage in healthcare? What are the key considerations for policymakers, regulators, and government end users of AI tools? How are key healthcare industry stakeholders responding to the impact of AI tools? And then who is responsible? Managing enterprise risk through robust government frameworks. Okay, next page. So what do we need to know to get started? Next slide. In this section, we're going to go through clinical and administrative applications, existing legal and regulatory landscape, and then what are U.S. policymakers generally concerned about when it comes to regulation of AI tools. Okay, next slide. So here you can see this really nice chart from GAO about some of the clinical and administrative applications. Clinical are in orange and administrative applications are in blue. So monitoring patients, guiding surgical care, recording digital and clinical notes. This is just a sample of what AI is currently being used for in healthcare, but we wanted to give you an idea of what we're talking about when we mean AI tools in healthcare. Next slide. We also wanted to set the stage about existing legal and regulatory landscape. We do not have to start from scratch. There is already an existing legal and regulatory landscape in place. You see here we have the Federal Trade Commission, the FDA, ASTP ONC, the Department of Justice, and then we also have case law, state laws, etc. There's already a number of laws on the books. Just because AI is a new technology does not mean that current laws don't apply. On the contrary, they do apply, and it's not just healthcare agencies that are implicated in health AI regulation. Next slide. So what are US policymakers generally concerned about when it comes to the regulation of AI tools? I'm sure some of you have seen in the news different actions from the White House and Congress that we'll talk about later. But I think the biggest one we've seen is transparency, also bias, which Maya will talk about later, national security, data privacy, election protection. These are the things that are really top of mind for people. As you can see, healthcare is not quite top of mind, but it's top of mind for us. So let's go to the next slide to continue. So what is AI and how it's defined? We're going to take a step back. Next slide. The key concepts in this section are going to be the federal government and statutory definitions, a historical overview, how did we get here, some key terminology that we think you need to know, and where the data comes from. Next slide. So as you can see here, we have two different definitions. As I said before, national security is one of the areas that Congress is very concerned about. So we have one of the first definitions in statute was through the National Defense Authorization Act. It's the term artificial intelligence means a machine-based system that can, for a given set of human-defined objectives, make predictions, recommendations, or decisions influencing real or virtual environments. Artificial intelligence systems use machine and human-based inputs to perceive real and virtual environments, abstract such perceptions into models through analysis in an automated manner, and use model inference to formulate options for formation or action. In the orange, we have the HHS definition, which is a little shorter, just that AI enables computer systems to perform tasks normally requiring human intelligence. So the key here is that we have a hardware or software replacing tasks otherwise performed by humans using predictive technology. Next slide. So how did we get here? ChatGPT just came online and it's, at the top of everybody's mind, but AI has been around for a while, particularly static AI, which I'll define later. The FDA has been receiving submissions with AI as part of it since the 90s and has its own process for regulating software as a medical device. So just to be clear that this is, new in the sense that we're really starting to feel it in society, but it's been around for a little while. Next slide. Okay, so a few key terms. You have a bunch here. There are a bunch more that you might need to know for AI, but we want to focus on the two that are highlighted because the vocabulary here is very important. As I mentioned, static AI is the algorithm where it's trained offline and used as is, which is kind of what we've seen up until recently. And then generative AI or Gen AI is what everybody's talking about. So this is artificial intelligence capable of generating text, images, videos, or other data using generative large language models, often in response to prompts. Gen AI learn the patterns through inputted data and generate new data that has similar characteristics. So when you hear about large language models, they are a type of generative AI. Next slide. So where does the data come from? As you can see here, it depends on the tool, the time period, and the quality way in which the tool was created. There were several class actions, like right after ChatGPT came online, that were filed, particularly in California, just basically alleging that ChatGPT scraped the data off of their website inconsistent with their web page's terms of use. So now I'm going to turn to Lynn to go on to some of the current pitfalls.
Thank you, Rachel. What are the current potential pitfalls and risks of AI tool usage, particularly in healthcare? Next page. Key concepts of this section are an overview of some lawsuits, and we even have a recent settlement as of yesterday that I'm going to speak about, privacy and data security risks, and bias. I'll do just a brief touch on bias. I call it garbage in, garbage out, but we have another speaker, Maya, who's going to do a wonderful deeper dive on how to manage bias. Next page. So one of the recent lawsuits, the lawsuits Rachel was talking about, were challenging the improper use of the data to create the large language models. These lawsuits are the use of the AI tool and that the tool did something to damage somebody. In this context, insurers have been hit, healthcare insurers have been hit with lawsuits stemming from their use of AI tools. Insurance providers contracted with subcontractors to use an AI tool to approve and deny patient care, and they were using it to minimize labor costs for processing the insurance claims. Class actions were filed, and they had very high error rates with the use of the tool. They were not being reviewed by clinicians. They were, and policyholders were appealing. Their rates were very low, and the insurers were making money from that. And that's one example. I wanted to mention a second example where we had a settlement yesterday. The Texas Attorney General secured first of its kind settlement with a Dallas-based artificial intelligence healthcare technology company. There were allegations that the company used the product at several Texas hospitals after making false and misleading statements about the accuracy and safety of the AI products. They had violated the Texas Deceptive Trade Practices Consumer Protection Act. That's a state FTC act. And these were AI products that summarize the patient's condition and treatment for hospital staff to help them by pulling out information from the electronic health record. What's most interesting about the settlement is that the company has now like an integrity obligations. One, they've agreed to accurately disclose the extent of the product's accuracy. They agreed to ensure that hospital staff using the tools to treat patients understand the extent to which they either should or should not rely on the AI products, requiring what is clear and conspicuous disclosures. And just a reminder, also in January, the Federal Trade Commission published a blog reminding all AI companies, not just healthcare companies, the need to abide by privacy commitments. Let's go to the next page. Other pitfalls, data rights and intellectual property. You need data to create an AI tool. So you must first make sure you have the legal authority to use the data that creates the tool in the first instance. Do you have adequate authority for the data that's going to train it? And then are you really the one that's going to own the resulting AI tool? Number two is the whole issue of intellectual property rights. Do you even own the rights to the tool? Some people are providing their data, but they only get a use right. They're not the ones that are going to own the AI tool. Next is cybersecurity risk, which we're all familiar with. The unauthorized access or tampering with the data integrity or the AI functionality could then be compromised if somebody interferes with the underlying data. And then finally, bias. So we call it not necessarily accurate AI, it's trustworthy AI. There's always going to be some sort of bias, and the goal is to minimize the bias. I call it my American Samoa example. If 95% is done accurately and there's 5% where there could be a challenge, an outcome that would be inconsistent with the outcome we would have wanted had a human done it, we need to figure out the workaround for the remaining 5%. If if no one from American Samoa was in the database, then perhaps if a patient from American Samoa presents herself, perhaps that person needs a workaround and not rely on that particular AI tool. So just to give some generic context, but Maya, our speaker later, is going to do a deeper dive. Let's go to the next page. And this is just a little bit more touch. There's all different types of bias data, computational, statistical. We had facial recognition, issues about people and whether a skin tone, misrepresenting prognoses, distorted financial predictions for loan applicants, underwriting for life insurance was distorted. And then we have human and systemic biases, ways in which certain groups are excluded. But once again, I just wanted to mention Maya's going to do a wonderful presentation. So Rachel, take us through the next section.
Okay, so what are the key considerations for policymakers, regulators, and government end users of AI tools? Next page. The key considerations that we're going to talk about here are some of the key ethical principles, the White House AI Bill of Rights, Congress, the White House AI Executive Order, states, and the Supreme Court. Next slide. So we like to start out with some ethical principles. The World Health Organization has this nice list to promote autonomy, to protect autonomy, to promote human well-being, human safety, and the public interest, to ensure transparency, explainability, intelligibility, foster responsibility and accountability, ensure inclusiveness and equity, and promote AI that is responsive and sustainable. So these are all very laudable goals. Next slide. With that in mind, we've had some action since October 2022 when the White House announced its blueprint for an AI Bill of Rights. Then Senator Schumer announced his Safe Innovation Framework for Artificial Intelligence of June of 2023. And then October 2023, we saw the Biden executive order on safe, secure, and trustworthy artificial intelligence, which was really the first time we saw healthcare mentioned and kind of an idea of where this would impact healthcare. So let's go to the next slide. Just very quickly, the White House AI Bill of Rights created a framework to build upon. Next slide. The Biden executive order on safe, secure, and trustworthy development of use of artificial intelligence impacted many, many agencies, not just healthcare agencies, but it was the first time that we saw HHS and other healthcare agencies implicated. I'll go into a little more detail about what the executive order did, but we're still to this day seeing news come out. Just yesterday, the HHS Deputy Secretary Andrea Palm said that HHS will release a new AI strategy by January to create an AI safety plan through assurance labs, which is a term I will define later. But that is a direct implication of the executive order and the administration putting new guidelines and information out. So next slide. Here's more information on what the executive order did. Very importantly, the executive order put a lot of timelines in place. So it wasn't just, we want this to happen and there's open-ended. They put a lot of very specific timelines in place. One of them was by April 27, 2024, HHS had to consider what's required to advance federal non-discrimination laws. They're needed to have the independent regulatory agencies were considered to use their full range of authorities to clarify requirements and expectations related to the transparency of AI models. And then within 60 days of the issuance, each agency had to designate a chief artificial intelligence officer to hold primary responsibility for their agency, to coordinate their agency's use of AI internally, and then also to promote AI innovation in their agency and manage risks from their agency's use of AI. So on the next slide, we see that they met all of these goals already. So HHS OCR released a final rule that clarified non-discrimination requirements in health programs within Section 1557 of the ACA. ONC, which is now the Assistant Secretary for Technology and Policy, released the HTI-1 final rule that established the first of its kind transparency requirements for AI and other predictive algorithms that are part of certified health IT. And then from my perspective, very importantly, each agency has now assigned a chief artificial intelligence officer. And this is kind of like how we see OIG at every agency. It's important to have someone who understands the agency and understands AI and can work within that regulatory scheme. So let's go to the next page. We turn now to the legislature, which is where I spent most of my career. Senate Majority Leader Schumer has his Safe Innovation Framework that he announced in 2023. This led to a lot of different AI insight forums. Healthcare was mentioned, but none of them were like specifically about healthcare. But in a way, it was interesting that instead of going through the committee process, which is kind of what we would call regular order, they had these AI insight forums and then created this bipartisan roadmap to kind of set up an agenda for legislating at a later date. Next slide. Here are some more congressional themes that Congress is focused on that we saw in the AI insight forums. Next slide. Originally, Senator Schumer wanted to do a large comprehensive bill on AI. That hasn't been possible. And so instead, we're seeing individual bills moving that may pass. As I said, the two main areas that they're very much focused on are national security and election security. So we have these two bills that have passed out of committee and many say might have a chance of passing into law before the end of the 118th Congress. Next slide. And then what's happening in the states? It's important to monitor the states, not just because they're taking action, but also because, as we've seen in healthcare, so many laws at the federal level come from the state level, right? So we saw the ACA was originally a state level. The No Surprises Act was kind of a combination of several states. Colorado and Connecticut were working on a bill together. Everybody thought Connecticut was going to be the first to pass, but it ended up not passing. It passed in Colorado. But Governor Jared Polis, who is, a tech leader himself and a civil rights leader, wrote a very interesting letter, essentially saying that he hopes that the federal government preempts that law before it goes into effect in 2026. We're seeing something similar in California. For those of you who've been paying close attention, there has been some national focus on one of the AI bills, SB 1047. That is going to try and prevent AI systems from causing large catastrophes, but people like Nancy Pelosi and Zoe Lofgren have particularly spoken out about a state bill, which is something that usually doesn't happen. So we'll see if Governor Newsom signs that into law. He has till the end of September, but we're seeing this happen a lot in the states, and it's just important to pay attention to. Next slide. And then just to promote a blog that Lynn and I wrote with some of our colleagues at EBG, for those of you who have been following the Supreme Court, the Chevron deference doctrine was overturned at the end of this session. Essentially what Chevron deference did was where the statute was ambiguous, the agency would get deference. We talk about in this blog how that impacts regulating something like AI, which is using existing laws that were passed before Congress could have intended AI tools to be within the scope of the statutory authority. So that'll be really interesting to watch how Loper, which is the case that overturned Chevron, impacts the regulation of AI and others. Next slide. So how are key healthcare industry stakeholders responding to the impact of AI tools? Next slide. We'll talk about clinicians, academic medical centers, state regulators, and the insurance industry. Next slide. So the American Medical Association has taken a leading role in addressing AI in healthcare. Their president, Jesse Ehrenfeld, has an interesting quote that I like to use, that AI won't replace physicians, but physicians who use AI will replace those who don't. The way that they talk about AI is also very interesting. They call it augmented intelligence instead of artificial intelligence. So where we talk about how the vocabulary really matters, by using the word augmented, it shows that there's going to be, some kind of human oversight or intervention with the use of AI. So we have a couple of slides here. We can go to the next slide and then the next slide about how the AMA is working on this. As we all know, AMA oversees the CPT code process, which is how people get paid. And so that's something that they're working on and interesting to look at closer. So the next slide is the response from academic medical centers and tech leaders. This is the Coalition for Health AI, CHAI, that has been mentioned before. Our fellow speaker, Nicoletta, is the scientific director for CHAI. And I know that Brian Anderson is going to be working with the Alliance on a future briefing. So that will be very interesting to hear about. But essentially, it's the nonprofit medical centers and various tech industry leaders that have joined together to try and develop guidelines and guardrails to drive high quality healthcare by promoting the adoption of credible, fair, and transparent health AI systems. And they are the ones that talk about these assurance labs, which I mentioned before that HHS just made the announcement for. Mickey Tripathi, the Assistant Secretary for Technology Policy and Acting Chief Artificial Intelligence Officer at HHS, said yesterday at Politico's Future of Patient Care and Access event that assurance labs are coming. What is an assurance lab? It's a place you go to take your AI tool and have it checked for bias, for other problems that it may have. Right now, they're actual locations, but I've heard at various conferences and talks that like the goal is to one day have them kind of on your phone. So maybe a doctor that's using ambient scribing can check very quickly to make sure that the tool he's using is up to par and something that he can be using. So very interesting to see like how CHAI is part of what FDA and HHS do. And then we have the Federation of State Medical Boards on the next slide, which is the response from state regulators. And they're kind of looking at it from the same way that we've seen these other organizations: equity and access, education and understanding, transparency and disclosures. These are all things that people are looking to utilize when addressing how to use trustworthy AI. Next slide. And then something that we've focused on is the National Association of Insurance Commissioners. As lawyers, it was very interesting to see that they had contract terms and definitions that they were providing for insurers who procure AI tools in underwriting. So now with that overview, back to Lynn.
So who is responsible? How do you manage enterprise risk? Next page, every company has a governance framework, a board of directors. So we're going to be talking about what makes an effective compliance program. Next page. Okay, so you have a potentially non-compliant use of an AI tool. You potentially violate a law. This is my life. I do Medicare, Medicaid. Clients make mistakes. They potentially violated it, whether it's an AI tool or a human error. The goal is to mitigate the risk of noncompliance. Well, we have federal sentencing guidelines out by the Department of Justice, particularly for violating criminal laws. And the Department of Health and Human Service, OIG, came up with a compliance program specific for healthcare, and they're doing it industry by industry within healthcare. But what's the benefit of these guidelines? The guidelines say that if you are a corporation, you cannot act like an ostrich with your head in the sand. You have to act responsibly and have some type of self-policing framework, usually called a corporate compliance program or enterprise risk management program, to be able to manage for risks of noncompliance with laws. And that compliance committee is created, policy and procedures, and if something bad happens, you get a discount. You may want to do a voluntary disclosure. DOJ just recently announced a new whistleblower reporting mechanism for violation of laws to get credit for coming forward. So this is the intersection of law and the real world of how companies, regardless of whether there is or is not a specific federal AI in healthcare federal statute, they have to operate compliant with all laws. And the best thing companies can do is have an effective compliance program. Next page. This is DOJ's information on what makes it effective. Next page. And this is HHS-OIG. Number 5, conducting internal and external monitoring and auditing. I just want to highlight that. So that if a human makes a mistake and you have 20 people working on it, you might want to check those errors maybe once every month or once every quarter. But when an AI tool makes a mistake, it makes a mistake systemically. So you may want to check that daily and take a sample every day because you need to catch it sooner and quicker. Next page. So this is the heat map. If you could click for a couple of times, it'll start to populate. If you haven't seen a heat map, many boards of directors use these heat maps for all enterprise risks, cybersecurity, talent searches. So this is one that we created for the creation and use of AI tools. Obviously, if it's likely to happen and if it happens, it would be severe. That's your upper right-hand corner. And if it's negligible, that it may not happen, and if it happens, who cares? That's the lower green one. So if a chatbot interview scheduling AI tool doesn't work, the company's not going to have a major problem with that. But if the AI tool is going to read an MRI, we're going to want to know that. And what this does is you have a committee that does a consensus. Do we all agree? And you add auditing and monitoring and policies and procedures around those in the red and the orange, and you may have less auditing and monitoring and policies for those in the green. And I know Nicolette is going to, from Duke Health, is going to be talking about how they created a specific governance structure just for all electronic algorithms that could impact patient care. And they have actually a registration. It's like a subgroup. We have been advising clients to use the 7 elements to create a dedicated compliance program for the creation and use of AI tools in healthcare. And it includes whether it's for scheduling or whether it's clinical decision support or reading the electronic health record. Next page. And this is our last page of content, how stakeholders get started creating these internal voluntary AI compliance programs. Find your stakeholders, get someone to chair it, create a charter like you would have a charter in the board of directors, take an inventory of the existing or desired tools, give yourself 4 to 6 months to get everything up and running, make sure you educate and do a heat map, create the implementation plan, audit and monitor, incorporate it into your overall compliance program. This is what we're doing day to day right now for our clients in the healthcare field who want to embrace AI, but in a corporately responsible way. And then I just want to highlight one more thing. Go to the next page. Next page. Okay, index, just very quickly. This is the index. I want to just flip through each page. If you could just turn the pages one at a time. Next page. These are the regulators for healthcare. This is Office of Civil Rights, the 1557 that Rachel mentioned. Next page. Next page. How does Office of Civil Rights look at it? Next page. How do you mitigate? And it says adopting governance measures, monitoring impact, written policies and procedures. That's why the 7 elements of an effective compliance program is the best way to do that. Next page. Clina, this is FDA guidance. Next page. Oh, and the ASTP, what they did, their final rule is in there. There's a couple of pages of that. Next page. Next page. FDA just the guidance on reaching inputs and outputs. Next page. Gave you some examples of software, of clinical decision support software. Next page. All the things the FDA has been doing, so you have a little cron there. Next page. And devices. Great. Next page. Maya, it's your turn. Tell us about bias.
Absolutely. Thank you so much, Lynn and Rachel. That was so comprehensive. I learned something new every single day. And without a doubt, that legal framework is so important in being able to deploy AI responsibly. And so I come from the perspective of a physician, a healthcare IT executive, where I spent the vast majority of my career leading healthcare systems, healthcare IT systems in academic medical centers, and then as a health equity advocate and innovator. And without a doubt, the AI hope is real. It's palpable in healthcare. And we know that there are so many challenges to operating healthcare today in the United States that there is this real true hope that wasn't here 2 years ago, 3 years ago, that AI, especially generative AI, may solve some of our most difficult problems. But before we jump into that amazing hope and opportunity, we have to ensure that we're deploying AI responsibly. And I'll be talking about specifically AI bias. Next slide. And so the dark side of AI, algorithmic bias. One thing that Lynn mentioned is just the difference between, say, a person who may be biased and have a one-on-one interaction, one-on-one decision making, and just the sheer scale of algorithms, of machine learning, of AI when deployed in healthcare systems. So this is an example of an AI model that was found to be racist. So Obermeyer et al. Did a study and found that a model that had been deployed in hundreds of healthcare systems was systematically denying care to Black patients who were equally sick compared to white patients. So they were able to measure that discrepancy and take a deep dive into why was that model biased and find the error that had occurred during the model development process. They fixed that error and were able to develop a model that actually identified risk equitably across patient populations. And that's what we want. We want models that work for everyone. Next slide. Again, that particular model had been deployed in hundreds of healthcare systems, at this point in time exposed to over 80 million patients. And so that scale, when we think about the scale of AI, is very different, like I said, than that individual impact of one person. So the history of algorithmic bias in healthcare has been recognized for quite some time. As early as 1976, it was noted in the book Computer Power of Human Reasoning that suggested that bias could arise and be embedded in data and coding assumptions in a computer program. Within the practice of medicine or healthcare, the first algorithmic bias model that was found to discriminate was recognized in as early as 1982, where an algorithm that was used to automate portions of admissions to medical school was implemented and found to discriminate against women and ethnic minority groups. I talked about Obermeyer's study in 2019. Now in 2020, as recently as 2020, New England Journal of Medicine began to question the use of race as a variable in a number of clinical historical algorithms that have been deployed as part of the practice of medicine for quite some time. Next slide. So algorithmic bias is not new, and it occurs throughout the AI lifecycle. So when we think about how models are developed, it's through a life cycle that starts with data creation, how data is curated, how it's acquired, to the individual decisions that data scientists, that developers make during the AI model process, to how the model is evaluated, all the way to how it's deployed. And that bias can occur throughout the life cycle at each of these stages. So we can imagine, for example, in data creation, that specifically healthcare data skews, it's biased, it skews towards sick people. Sick people are actually overrepresented, no surprise, in healthcare data. So our older people are overrepresented in healthcare data. Marginalized or patient populations that don't seek healthcare as frequently while being equally sick are underrepresented in that data set. During that model development process, individual data scientists make a lot of decisions. They make assumptions. And in the case of the Obermeyer example, the assumption was made that healthcare spend was a good proxy for healthcare risk. And it turned out that Black patients actually spend less healthcare dollars when they are equally sick. So that was the error. It wasn't any kind of malicious intent by the developers, by the developer. It was just an assumption that the amount that you spend, if you spend more, you're going to be more sick. And that is true, but that historical experience of Black patients being less likely to spend while being sick was perpetuated in the model. All the way to how we evaluate models, and I'll talk a little bit about model evaluation process and how models are deployed. So you can have a perfectly debiased model, but you deploy it in a flawed world, in a world where decisions can be influenced, and why we need to continue to monitor those models over time. Next slide. So the good news, next slide, so the good news is that throughout the AI lifecycle, there are wonderful bias mitigation methods. These are methods that AI research scientists have developed throughout the years to both detect bias and mitigate bias. And some of the methods are social mitigation methods, and some of the methods are technical mitigation methods. So for example, diversity of teams. If you have teams with a diversity of lived experiences, so for example, in healthcare, ensuring that we have patients, that we have clinicians, that we have health operators, all part of the team that is developing these models is really important to encompass the full experience of what may be driving a particular model. AI governance, which Nicoletta is going to talk more about, so important in mitigating that risk. And then regulations. So there's a role of the evolving regulations and ensuring all that there is a standard that ensures that we are all on a path to having models that we're exposed to that help us all. And then to some of the more technical methods. So the technical methods include a lot of open source and newly emerging methods where you actually measure that bias and then apply statistical technical methods for mitigating bias. And then, as I mentioned, monitoring for outcomes, stratified by different demographic groups. Next slide. And so, the role of policymakers in promoting responsible AI is very clear. It's recognizing that bias exists, but that we also have really good tools for both detecting that bias and mitigating that bias. Our regulations ought to leverage the work of existing standards. So for example, NIST's AI risk management framework that incorporates bias detection and mitigation as a standard. And then funding. Of course, one of the roles, levers that policymakers have is funding, and it continuing to fund AI evaluation research. So definitely a focus of NIH in ensuring that we continue to have robust evaluation methods as AI becomes more and more sophisticated. And then education and workforce development. The next, when it comes to healthcare specifically, is ensuring that we're incentivizing responsible AI use across a wide variety of healthcare delivery models. And so often we'll think about healthcare delivery in a traditional fee-for-service or a value-based model. How do we ensure that we're incorporating those innovation around AI in a way that incentivizes value-based care and better care, especially for our dual eligible, our Medicare, our Medicaid, and our underserved populations that are often funded by these different healthcare models. So I leave that to you, healthcare policymakers, when you're thinking about how you use your levers to drive change, is regulations, funding, and incentives. Thank you very much.
Wonderful, Nicoletta. I'd love to hear from you on governance.
Hello, my name is Nicoletta Economou, and I'm the founding director of the oversight program that we've stood up at Duke in order to govern, monitor, and evaluate all algorithms to be deployed in our health system. Thank you. I would like to thank, first of all, the organizers for inviting me to present some of our work in the AI governance space. Next slide, please. So just to do some basic framing, the healthcare landscape when it comes to AI solutions that are being deployed is it's almost like the Wild West, right? You have different AI solutions for different purposes being deployed in different environments, different departments. You have different types of end users, so those might be clinicians or schedulers or executive leadership or others that are caregivers that or sometimes even population health. So some of our key kind of like Duke workforce that are supporting, if you will, patient follow-up and providing more information to patients and helping with some like social workers and other care for our patients. The variability of where these AI solutions are developed is also something that I wanted to mention. Some of them are developed internally, being an academic medical center at Duke, but some of them are acquired, they're procured. And some of them, because we're a research organization, are co-developed. We call them kind of hybrid because those might be co-developed with an industry partner. And of course, it's worth mentioning there's some algorithms out there that have machine learning or logistic regressions or kind of like other types of algorithms that may be used in standard practice in clinical care. Those might be mentioned in medical literature, or they may be part of guidance from medical societies. And then thinking through not only the AI model itself, but also the applications that they're presented in. So sometimes these algorithms or AI models are presented within Epic or within other interfaces such as Tableau, or they might be part of different custom apps that are being developed within our organization. Next slide, please. So out of our utmost focus on high quality care for our patients, we were tasked back in 2020 to form an AI governance structure and think through what we would do in order to get a handle of the landscape and also ensure the quality and ethical deployment so that we ensure the safety and fairness and equity for our Duke patients. In this slide, I just wanted to call your attention to the colorful kind of a line of like that iterative life cycle of model development and how sometimes that stage might be replaced by the whole procurement and selection process. But then after that, there is testing that needs to be done before solutions are deployed into the real world. That's where you see the effectiveness evaluation. And that typically we expect will be a more controlled environment like a pilot or a small scale deployment of the AI solution before it's generally deployed. And during the general deployment phase, we want to make sure that project teams actually monitor the AI solutions. So what we've done is we've introduced just-in-time checkpoints. So we reimagined what this life cycle looks like for our organization, and then we basically decided when to introduce just-in-time checkpoints so that we can look at evidence of what exists for these AI solutions at specific time points, as well as future plans for deployment. And the reason for that is to embrace a mentality of quality by design, ethics by design, health equity by design, so that early on we can educate also and collaborate with project teams so that best practices are in mind. So for example, that we're thinking through the workflow, that we're meeting regulatory requirements, that we're looking at all aspects of fairness, fairness and equity, impact and safety, transparency and accountability, and we've basically decided upon our key principles, very much like what we heard our previous presenters talk about. A key component here is that we, through our process, are driving accountability. So essentially, we're asking developers and the assigned business owners, what are the outcomes that you're trying to improve upon? And we're asking these questions early on so that we can ensure that these products are meeting their intended purpose. We're also just by default defining the technology owner and the business owner, or what we call clinical owner, will ensure that we actually have accountability for the technology and the presentation of the clinical use case or the business use case that this solution will be implemented for. And then because sometimes, some of these AI solutions may be fruit from a pilot or a research activity, we also want to ensure that we have an executive sponsor assigned as well, as we talk about kind of personas within this accountability framework that we assign. And then we continue to ask questions throughout our process about, how will this tool be integrated into the workflow, right? There might be regulatory repercussions, and we heard about this a little bit earlier today about, the training and the information and the disclaimers or disclosures that we are presenting to end users and those involved. Next slide, please. And so one of the first things that we did is we assigned an ABCDS oversight committee, a governance structure that is multidisciplinary and cross-disciplinary, because just as these solutions require an informaticist, a data scientist, an end user representative, and in some cases a patient representative as well, if we're following best practices. In the same sense, we needed to kind of mirror that with also a committee that would be able to have that breadth and depth of expertise. And it is this committee that also reviews the actual AI solutions that are deployed within our health system, or they would assign somebody, a subject matter expert or somebody, to perform those reviews. Next slide, please. The utmost first step, though, is to gather from the business owner and the technology owner bare minimum information that will allow us to understand what these AI solutions are. And so we have created an inventory of tools, and that registration process is the first step when we first interact with the project teams. And then depending on the review and the risk, right, we perform a risk assessment, and depending on the level of risk of the tool, we would basically also perform an actual review of these, independent review of these AI solutions. And then throughout the life cycle, we expect that our project teams, essentially our clinical owners and business owners, will update this registration information so that we always keep that information up to date, as different versions may change, different uses may change, and that is to be expected sometimes throughout the life cycle of these technologies. Next slide, please. So the first step, not not all algorithms, right, that we deploy at Duke actually impact how we're delivering patient care today, but a lot of them do. So as far as scope, all electronic algorithms that could impact patient care at Duke Health fall within the scope of our oversight process and must undergo registration. And then we have a triage process where we then determine if they're high risk, medium risk, or low risk. So standard of care solutions would be some of those low risk that we do not review ourselves, but we do hold the business owner and technology owner accountable for ensuring that those are of high quality, they're safe, they're fair, and that they're checking them at specific intervals. Next slide, please. So these are the main principles that as a committee we have basically agreed upon. And the most important piece, going back to kind of like the theme that we heard around education, is that we created an implementation guide for our Duke community in order for them to understand the principles, but then understand what's expected at each checkpoint throughout the process, so that we would be able to bring a broader understanding of what the expectations are for a solution to meet these principles of quality and ethics. We also provide example material to the project teams so that they can tangibly understand kind of how to perform some of these duties, and how they can also demonstrate, let's say, impact or perform bias assessments, right? So we have a framework just to describe the different types of biases and also how those biases can be assessed and mitigated. Next slide, please. And so operationalizing trustworthy AI in healthcare is actually very important. Here's the publication around the bias framework that we recently published. But you know, this is work in progress, and we first decided that we'll set up the governance structure so that we can establish our evaluation criteria. We created that inventory through the registration process, and we continue to educate project teams. There's also that risk-based evaluation framework so that we can also prioritize and define which AI solutions are of higher risk and how those should be evaluated accordingly. Next slide, please. But all in all, this oversight process is essentially very much like the quality management system that you might be aware of for drugs and devices. And we do need to put policies in place. We do, and we're essentially establishing that, and SOPs. We need to qualify project teams so that they're we basically have a proactive approach into looking at quality and ethics when we're deploying these solutions, because it is a culture shift, I think, for organizations as they adopt AI, and for them to also understand, you know, what their responsibilities are when it comes to testing, when it comes to performance, when it comes to design. And I think the field is going there, but it is organizations such as the Coalition for Health AI that will help us as a nation kind of like in a consensus-based fashion come up with a common understanding of what that should look like. Next slide, please. We've definitely seen benefits beyond compliance on implementing an AI governance structure. There are many learnings, but definitely we have more organizational transparency into the ethical and quality deployment of our solutions. And we've been driving accountability and business continuity and also, you know, we've also unraveled a lot of kind of like equity and fairness cases so that we can now work collaboratively with project teams in order to also reach a common understanding. But these are frameworks and AI governance that we're doing here in healthcare. It's basically something that can be also performed, right, in other settings across the government as we think about portfolios that you may reach. So even if you are creating AI solutions in-house or acquiring external solutions, it would probably follow a very, very similar life cycle. And we have articulated a very nice agile life cycle with the Coalition for Health AI Assurance Standards Guide. Next slide, please. And we're working with other healthcare organizations to also look at, how could we scale across governance across different organizations. And then we also have a project with Vanderbilt University in creating a maturity model framework, and we're engaging stakeholders on that. But this is an ecosystem. So we're thinking through a lot of these health AI governance, not only locally, but at large. And so could we have a national registry, for example, so that we would be able to have transparency as a nation into what the outcomes of some of these solutions look like and where are they deployed. We're also thinking through kind of the whole safety landscape, right? And what kind of infrastructure, and can we leverage the infrastructure that we already have right now in healthcare in order to do our risk management framework? And what does this safety ecosystem look like, right? There needs to be a developer implementer, especially if they're not in the same organization, kind of interaction in order to also make developers aware of the risks. And it's not an easy exercise, right? But there is a communication that can be also part of the negotiation phases with external parties when you're thinking through kind of how to go about safety and deployment, so that then when other organizations face the same risks, mitigation strategies are established across for the same solution across different entities. I would like to thank you again for giving me the opportunity to talk today, and I'll hand it off to the next speaker.
Thanks so much, Nicoletta. Well, I'm actually going to invite you to stay on camera, and I'll ask all our speakers to join because I have a few questions I would love to share. And then we also have some questions from our audience as well. So thank you all so much. What fabulous presentations. I wanted to share with Rachel and Lynn. We did get a shout out for your heat map. People really like that, and in fact, this will warm your lawyers' hearts. Someone said it reminded them of the liability index that Judge Learned Hand uses on the BPL. So that's a very inside joke for our lawyers in the audience. I will say we have so many different perspectives here from our experts and different capabilities. So we're hearing from people with really deep technical expertise and clinical care expertise, people from the law side. I'm just so pleased with how rich this conversation has been with those different perspectives. And it really shows in AI, it's not going to take one kind of expert, right, to be at the table. We know we need to bring diverse perspectives and deep knowledge and expertise. So Rachel and Lynn, you shared a lot of information. I was wondering, just from a practical standpoint, we have a lot of curious learners who join our Alliance programming. And if there was, when you think back, if there's one or two resources that you would recommend that people read that maybe shifted your thinking on AI and helped you think differently about it, I think Rachel and Lynn, I'd love to hear from you on that one.
Rachel, you want to go first?
Sure. So Lynn and I actually both did classes through the Harvard School of Public Health AI training. So that is where I kind of got my base. But I think really understanding how AI is actually being used in healthcare. So really reading a lot of trade press and just following the different organizations that I mentioned that are really leading in this space, to just see what their members are asking for and like what they're thinking about in terms of implementation. That has been really helpful for me. So once you understand the basics of how AI works, I know for me, I was a little scared of AI. I'm not an early adopter of technology. So hearing that it's just a predictive tool calmed me down a little bit. So understanding the basics, and then once you do that, just seeing how different organizations throughout the industry are responding to it has been very helpful in my education.
Yeah, I
Awesome.
would add. Yeah, I would add, if one of Rachel's pages shows the lawsuits that are in the Northern District of California, and reading the court pleadings in those cases is really a very good resource. I'm not sure everything is accurate because it's advocacy, but that whole issue of generative AI and whether there were violations of terms of use in using scraping websites, how these large language models were created, particularly if you want to get more of an understanding of Gen AI, or at least what people are talking about when it comes to Gen AI, those court pleadings are very interesting to follow.
Great, that's awesome. Maya, I'm going to turn to you. We had quite a few questions from our audience as well, so there'll be more on bias. But one of the things that struck me is that you've worked in a large enterprise, University of Chicago. You're now working with different kinds of health systems with all different levels of resourcing. And I'm wondering, what differences you see in the ability to take on, complex and difficult problems like bias in AI. How does that differ in different resource settings?
Yeah, it varies tremendously, as you can imagine. We have some extremely well-resourced academic medical centers that not only have pretty generous margins, but also trained PhD data scientists, have faculty members that are at the cutting edge. And then you have the rest of us. And I would say the rest of us include both on the far end of the spectrum, FQHC, federally qualified healthcare systems that these are all nonprofit healthcare systems for the most part, but the margin for an FQHC is like 0, maybe negative, whereas the margin for an academic medical center is pretty significant, or a lot of our nonprofits are pretty significant, and that margin often funds innovation. It funds the ability to dedicate resources, whether they're human resources, time, money. There's different types of resources, of which they're all scarce on the FQHC. In the middle, you have plenty of healthcare systems that have one type of resource. They might have a little bit of margin, a budget where they can invest in AI, they can invest in purchasing AI systems, but they may not have the technical capability, the human resource capability to be able to appropriately evaluate the models when deployed in their healthcare system. Because often their IT teams, they might have an analyst or maybe somebody with a master's in data science, but they're not going to have your academic research scientists like you do at these large AMCs. So there's a huge variation when it comes to all types of resourcing. And that's one of the biggest challenges, I think, when it comes to scaling effective AI governance, scaling at the local level, the ability to really ensure these models work for each and every individual that it's exposed to, regardless of care delivery setting. Hence why we need your help, policymakers, because that's where we can, define the floor and really provide better access to resourcing. Actually, Duke has a really great program where through, and I can't, Nicoletta, you probably tell me more about, share more about it, but where Mike Pensina has a program where it really is almost like a dyad relationship between, say, academic researchers at using the ABCD and all of the expertise that are being developed at Duke, and then having this collective of FQHCs and other low resource settings be almost like paired. Like, can that be AI governance in a box? Like, is there a way to create these relationships between better resource and less resourced systems. So that's
a
just
great question. I'm going to give you a follow-up, Maya, because there's a lot of interest in our Q&A online in the bias topics. And that is, okay, so we're talking about that at the systems level, different levels of resources. We know that has a huge impact and ability, capability, and just resourcing to be able to implement or to take on or to get the best out of these systems, right? Folks in the Q&A were very interested in how does this impact patients, and particularly we think about like low health literacy patients and patients who perhaps have a very high stakes relationship with their health system, have a lot on the line, but aren't as well equipped or well resourced individually to understand how some of these systems work. So just wondering if you have thoughts on that and what kind of resources are or should be available.
Yes, so just like there is a digital divide when it comes to digital literacy, there is a divide when it comes to health literacy, and there's a divide when it comes to AI literacy, right? And at the individual patient level, I think one of the big challenges is maintaining trust. And so despite these barriers around disparities in literacy, we still have to maintain trust. And so if we violate trust with patients because they feel like they have been biased or discriminated against or harmed by an AI model, then that erodes trust in our healthcare system, that erodes trust in our care delivery process, and ultimately actually just makes it more challenging for that patient to seek the care that they need. So I think there is a level of responsibility around increasing that access to digital literacy, to AI literacy, to our patients, making sure that we're a good resource, whether we're a healthcare delivery system, we're the government, whoever the we collective is, that we're really addressing this AI literacy gap, and that we maintain this trust through transparency. And that means working really closely with community groups and understanding, they're using ChatGPT all the time. I mean, they're using AI systems, right? So whether it's the algo, and the kids know it all. The kids are always so funny, right? They're like, I'm playing against the AI, or the algo gave me this, or the algo gave me that. So the lingo is out there. And so it's up to the collective us to harness that interest and fascination and make sure that it's directed towards, say, healthcare and education and all of these really important areas. And that we're equipping our patients, our communities with tools so that they can navigate this quagmire as well.
Great, thank you. And I think, it's not like there's a lot of easy answers, right? You talked about the digital divide and health literacy. Like the health literacy is an issue we've been working on for years and years and years, right? And so when you add sort of AI on top of it, that is an interaction, right? Like it is one on top of the other. They're not independent. So Nicoletta, I have a detailed question actually from our Q&As, and I will just take a moment to encourage our audience. We've got a couple great questions. Now's a wonderful time that you've had a minute to think about these presentations, just to add a few more questions to our list. So please go ahead and click on that questions bubble and submit some questions for us. We'd love to hear more from you. Nicoletta, one of the questions is kind of a detailed question from your slides, your wonderful slides. And one of the participants was wondering what was classified as a low-risk solution, used the term standard of care. And one of the participants was saying, okay, so how do you define standard of care? Which, can vary. So I'd love to know if you have thoughts on what goes into that. What are sort of your ingredients, if not your recipe, right, for standard of care?
Great question. Very good question, because, sometimes when we're doing this triaging, some of our folks in the Duke community is like, this is standard of care. We need to be like, is it really? So I like to think about it like the FDA calls it clinical association. So what evidence do you have out there in the literature that will justify that this is used in day-to-day care? Textbooks is definitely one thing. Guidance from medical societies is the other. The other thing I would say, which is unofficial, and we always verify about this, is like if something is an MD Calc, right? In this triage process, we always have a clinician involved. So I do not have a clinical background. I have a PhD background, not a clinical background. And so that's where we rely on, somebody with a medical background to also help us if there are any questions, right? And they also review. In some circumstances, we will reach out to a subject matter expertise if we still have questions. And especially, let's say, if there's something may be used off-label, right? Like for something that's not indicated, right? Or whatnot. So there are always nuances, but the algorithm per our process, we need to have evidence that it's for a specific intended use, and that's also being met. But that's an excellent question. I actually really appreciate it. And I didn't talk about, because I didn't have time, but EGFR is a very good example on why some of these algorithm-based clinical decision support tools need to be looked at with scrutiny. This is an algorithm that was used, it was, I believe, a logistic regression. It's a machine learning algorithm that was, in guidance for kidney failure. It's an indication for kidney failure. And, they were using what we call sensitive variables, so sociodemographic variables within this algorithm. The medical society itself actually corrected the guidance after it was raised and a new algorithm was developed for EGFR that corrected, and instead of using that sociodemographic variable, they actually are using a lab test. So that is to say, we as a committee don't do our in-depth independent review, but we do have, as part of our process, we do request that those accountable are looking and ensuring that these algorithms are safe, fair, and efficacious, right, of impact, because each population does vary from organization to
I'll just add briefly as far as the So for race-corrected EGFR, Stat News just like last week did a whole video. I actually happen to be in the video, but they did it. Yes, so if you check out Stat News last week, they went through and actually walked through a patient. So a patient gives her experience of being delayed a kidney transplant because of race-corrected EGFR and how her position in the kidney transplant list improved after race-corrected EGFR was eliminated, after the race correction was eliminated. It's a wonderful story and really personifies how algorithms can impact individual care. And then as far as like standard care, I would say Lynn and Rachel, right? Like you probably have tons to say about standard care, because I literally think of it as my floor. That's my safety zone. If I'm practicing within the standard of care, which can be quite wide, then I am generally going to be okay as a provider, as a physician in my clinical decision making, if I'm within standard of care. If I vary from standard of care, woof, then I'm at a legal risk of malpractice. And often we'll use standard of care as low as 2 cited articles that support your clinical practice. And so of course, Rachel and Lynn is far more expertise, and that's what we turn to when we have questions, is our risk people. Am I within standard of care? I think so, but I'm not sure.
Yeah, we ask the people with the right degrees, right? But I think this is a really rich discussion, and I think there's a lot of interest here in terms of this interaction between clinical decision making and AI, right? And so I think that that is just a really rich area, and I think we will see a lot more, activity and learning in that area, and a lot more questions. I think, clinicians have a lot of questions, right? When we've worked with those folks. I think the other question that I see here for Rachel and Lynn is that the regulator emphasizes the importance of conducting internal and external monitoring and auditing, but doesn't provide detailed best practices, right? So, we're talking about standard care, we're talking about detailed best practices, right? Considering various options, such as performing post-deployment monitoring of AI in production every few days versus few months, what are your thoughts on what compliance teams are starting to think about? And honestly, Nicoletta or Maya, if you have thoughts on that too, you're welcome to join. But Rachel and Lynn, if you have initial thoughts on the regulatory side, I think that would be really helpful.
Sure, I'll take a stab at it. Even if there were no AI tool, let's say you're doing revenue cycle management, you're billing the Medicare program under Medicare Part B, your chief compliance officer has an obligation to figure out how to do sampling, take a look at a certain number of claims, look at the way in which the government is auditing, look at the OIG work plan, look at what the MACs are doing, look at what the TPE audits are going after. And if you see that a certain CPT code or HCPCS code is being disproportionately the focus of false claims, you're going to want to do those more frequently than maybe other claims. Or if one claim represents 95% of your billing, you want to do a lot more. So it's a cost-benefit analysis that way. The fact that you have AI tools, I made the point that if an AI tool is wrong for a particular purpose, it will be wrong systemically, because it's not going to make a mistake of its repetitiveness, but it does. And if it's not static and it's going to change based on new data coming in, your frequency of auditing and monitoring needs to be greater. There are companies that are asking external advisors, data scientists. We have several that are on our EBG advisors consulting list, where those types of data scientists may give suggestions so that it's not the company alone that's making the decision on the frequency. There's a certain amount of protection and objectivity by asking a third party to give a recommendation for the frequency. But I will tell you, sometimes it's a matter of the hotline. And in fact, I've recommended that companies have a dedicated hotline for AI complaints and not just use the generic hotline for compliance issues, because it'll get a little bit slowed down and lost in the bigger hotline. And if you know somebody left a complaint, one of your employees left a complaint about an AI tool, you want to jump on it within 24 hours or 48 hours. You don't want to wait for the normal sequence of compliance hotline calls. And there are some hotline calls you want to jump on anyway. But these are the types of cost-benefit analyses that companies are looking at to make sure they're acting as good corporate citizens.
Yeah, and
Awesome.
I would just add to that very quickly. I was on a call the other day with a client where I asked, okay, you're the team that sets up the AI tool. Are you also the team that would take it down? And I don't think anyone had ever asked them that question before. And I think that's something that we constantly have to be thinking about. Like, all of the rules are changing, the regs are changing. There's going to be different types of legislation. It's a constant, it's not a set it and leave it governance structure. You have to continue to monitor it and update it as we go.
Awesome.
Yeah, and
Well,
I would just add, I was just sorry.
we could go on for, I think, another 4 hours, but I do have to do my thank yous, and so I wanted to thank everyone for joining us. I will say this conversation will continue. We are hosting a congressional briefing October 2nd, specifically on standards. Please do take our survey. We want to hear from you. What worked? What didn't? What could we do better? All of that, information helps us, create better events next time. We'll be hosting that. There's also a ton of information on our website in terms of the work we've done thus far in AI. I really encourage folks to look at our summit panels, which had excellent speakers as well. And I think I just want to land on, there'll be in the next couple of days, you'll be getting a link to this as a recording in case you missed anything, you had to walk away for a moment. And I'm just deeply, deeply grateful for everyone sharing their perspectives. I think this was such a rich conversation. I wish we could all go to lunch together now and I could ask 10 more questions. And hopefully all of you captured that energy and all that deep content as well. So thank you all so much. That concludes today's webinar.
Thank you.
Thank you.
Thank you.